Okay, welcome to the deep dive. We've got a fascinating challenge today, really getting into the weeds on chapter 79 of a medical text. The focus, breast cancer.
Yes, it's quite the chapter. And when you look at the scope, it's incredibly broad.
It really is. It covers everything from the fundamental biology, right? Understanding who gets it, why.
Exactly. The risk factors, how we find it, early screening, evaluation.
Then the whole world of treatment surgery, systemic therapies, all the way through to survivorship, even special cases. It's a lot to unpack.
It is. It's clearly designed to give someone, maybe someone like you listening, that foundational knowledge needed to, really grasp the field at a deep level. The scale mentioned is striking too.
The numbers, yeah.
Yeah.
What did the source say for 2020?
Even back then, nearly 250,000 invasive cases diagnosed just in the U.S.
250,000.
Plus another, 61,000 in situ cases, and sadly, almost 41,000 deaths related to it in that year alone.
Those figures are stark. It just hammers home why this is such a critical area. It's the most common cancer in women, right? If you exclude skin cancer.
That's right. It makes up about a third of all female cancers, roughly. But, and this is important, the chapter also points out some real progress.
Which is good to hear.
Absolutely. The mortality rate, it's actually decreased by more than a third over the last, say, 3 decades, at least in high and middle income countries.
And that's attributed to?
Directly attributed to 2 key things: detecting it earlier and just having much better, more effective treatments. And that hopeful trend, it really sets the stage for why digging into this material is so valuable.
Exactly. So our mission today, for you listening, is to navigate this dense chapter together. We want to pull out the crucial insights, try to cut through some of the complexity.
And help you understand this topic with the kind of nuance that, the top professionals in the field rely on.
Think of it as a shortcut, maybe, to getting really well informed, using this chapter as our guide.
It's about seeing the connections, right? How the biology informs risk assessment.
Which then influences screening.
Which drives treatment choices and even impacts survivorship care. The chapter actually calls breast cancer a paradigm for solid tumors because of this.
A paradigm. Tell me more about that idea from the chapter. What does that mean exactly?
Well, it's this idea that breast cancer sort of serves as a model for the whole journey of a solid tumor. The source lays out this continuum, stretching all the way from assessing risk and thinking about prevention, then moving into screening, early detection, evaluating anything suspicious.
Right.
Then the treatments themselves, local stuff like surgery and radiation, the systemic adjuvant therapies for microscopic disease, treating metastatic cancer if it spreads.
Even what happens after survivorship.
Exactly. It covers the whole life cycle, so to speak. But importantly, the source also notes, and this is key, not all breast cancers follow this neat path.
Okay. It's not always sequential.
Precisely. Every cancer is different. Which brings us right to one of the most fascinating parts highlighted early on. The unique biology that actually allows for targeted strategies.
Yes. This is where it gets really interesting, I think. The idea of subtypes.
It is. The source immediately says, look, breast cancer isn't just one disease, it's really a collection of diseases, and they're characterized by specific biological markers.
And the big ones are?
The key players, really foundational to how we understand and treat it today, are the estrogen receptor, ER, and HAR2, which is human epidermal growth factor receptor type 2.
So knowing if a cancer is ER positive or HER2 positive is absolutely critical information.
It's fundamental. And beyond those receptors, the chapter gets into the genetic changes. And here you have to understand the difference between inherited changes.
Germline mutations.
Germline, yes. Although the source actually prefers calling them SNPs, single nucleotide polymorphisms, which is maybe more accurate for inherited differences.
SNPs, okay.
Right. These are differences you're born with in every cell. And then you have the acquired changes, the somatic mutations.
Which happen just in the cancer cells themselves.
Exactly. They're not inherited. They develop as the cancer grows.
Like the BRCA1 and BRCA2 genes.
Yeah.
Are they germline or somatic?
BRCA1 and 2 are the classic examples of inherited susceptibility genes, so germline SNPs. But the chapter also mentions acquired somatic mutations in genes like MTOR, CDK46, PIK3CA.
And these somatic ones drive the cancer's growth.
Often, yes.
Yeah.
And they become targets for some of the newer therapies. The chapter even mentions immune checkpoint inhibitors for certain types. So right from the get-go, you're seeing this picture of complexity, but also personalization based on the specific biology.
That seems to be the core message from the introduction, really. Understanding the molecular details is key.
Absolutely. It underpins everything else.
All right, let's dig into the next section then. Epidemiology and risk factors. Who gets breast cancer and why?
Well, the source is very clear on the two biggest factors, age and sex. About 3/4 of cases, 75%, happen in women over 50.
But not exclusively.
No, definitely not. It's not uncommon in younger women, 40s, 30s, even sometimes 20s or adolescents, so that's rare. And the sex difference is just huge.
What was that ratio again?
Roughly 150 to 1 female to male.
150 to 1. Wow. That disparity really points towards the hormonal influence the source talks about, doesn't it?
It really does. The chapter really emphasizes that breast cancer is principally a sex hormone-dependent disease. It's driven by the activity of the estrogen receptor and the estrogens themselves, like estradiol and estrone.
So more exposure to estrogen equals more risk, basically.
Increased relative exposure, yeah. Whether it's estrogen your body makes endogenous or from outside sources exogenous, it's linked directly to increased risk.
And the chapter gives specific examples related to menstrual cycles and pregnancy, right?
All right. Yes. Classic examples. Starting your period early, before age 12, that's early menarche, increases risk. And having your first full-term pregnancy late, after age 35, also increases risk.
And the opposite is true, too. Things that decrease exposure.
Right. Things like not having functioning ovaries, going through menopause early, or never having used combination hormone replacement therapy, those all decrease risk.
And there was that really interesting point about breastfeeding.
Oh, yeah. That's quite striking. The duration of maternal nursing actually correlates with a substantial reduction in risk. And the source says this is independent of how many kids you have or how old you were at your first birth.
That's a specific detail that really stands out. It shows how complex these factors are.
It does, and it ties into the geographic variation the source mentions too. Huge differences in incidence rates across countries.
And most of that difference is explained by
differences in menstrual and reproductive history, believe it or not, about 70-80% of the variation. Much lower risks in, say, agrarian parts of Asia compared to North America or Western Europe historically.
But that changes with migration.
Profoundly. The source notes that Asian women who immigrate to the West during their preteen or teenage years, they quickly take on the higher risk profile of their new country.
Wow.
And as countries in Asia industrialize, their incidence rates are climbing dramatically, getting closer to Western levels. It really highlights how environment and lifestyle interact with any underlying predisposition.
Okay, let's tackle those outside hormones, exogenous ones. Oral contraceptives first. What's the verdict there?
The source describes it as a modest risk increase, if any, but crucially, it balances this potential small risk against the benefits.
Like preventing unwanted pregnancies.
Yes, and importantly, providing significant protection against other cancers, specifically ovarian epithelial and endometrial cancers. So it's not a simple good or bad.
Right, a trade-off. What about hormone replacement therapy, HRT? That's often discussed.
Okay, here the source makes a key distinction. Combined estrogen and progestin HRT does increase breast cancer risk. The text indicates that using it for 6-7 years can nearly double the risk.
Double? That's significant.
It is. And it also increases the risk of adverse cardiovascular events. Now, it does offer some benefits, like reducing bone fractures and colorectal cancer risk.
But overall?
Overall, the source concludes that combined HRT is associated with more negative than positive events, primarily due to that increased breast cancer and cardiovascular risk.
Okay, but what about women who've had a hysterectomy and only take estrogen?
That's different. The source states that estrogen alone HRT in those women does not significantly increase breast cancer incidence. In fact, it might even slightly decrease it.
So that really points the finger at the progestin component in the combined HRT.
It strongly suggests that, yes. And another important point, if you stop taking HRT, the risk drops relatively quickly.
Oh, really?
Yeah, studies show the elevated incidence declines rapidly once HRT is discontinued, returning towards average levels. They also caution against using so-called bioequivalent estrogens, like from soy products, as substitutes because there just isn't comparable safety data.
And what about women who've already had breast cancer? Can they use HRT?
The source is pretty firm here. Generally, no. Especially if the original cancer was ER positive, HRT could counteract the effectiveness of anti-estrogen therapies like tamoxifen.
Even vaginal estrogen for local symptoms.
Even that. While it's effective locally for things like vaginal atrophy, the source notes there is some systemic absorption and estrogenic effect. So it should generally be avoided in women on anti-estrogen therapy.
Okay, moving beyond hormones and reproduction, What other non-genetic factors pop up?
Well, the source mentions several, but notes that they generally have less impact on risk compared to age, sex, and hormones. Diet's role, for example, is described as controversial.
Controversial how?
There are associative links, between higher caloric or fat intake and risk, but it's not definitively proven to cause breast cancer independently. It might intersect with hormonal factors.
But obesity, metabolic syndrome, type 2 diabetes, those are listed as risk factors.
Yes, for both getting breast cancer in the first place and for it recurring after treatment. Moderate alcohol intake also increases risk. The mechanism isn't fully understood. Interestingly, the source mentions that taking folic acid might modify this risk in women who drink, but not in abstainers. It's complex weighing that risk against potential heart benefits of moderate alcohol.
And depression.
Also associated with both occurrence and recurrence risk.
Okay, last category here. Pathologic findings and radiation history.
Right. Certain findings on a breast biopsy, even if benign, can signal higher risk. Things like atypical hyperplasia or radial scars.
And radiation exposure.
It's a risk factor, but the age at exposure is absolutely critical. The risk is principally linked to radiation delivered during adolescence or the early childbearing years, specifically under the age of 30.
So radiation later in life doesn't carry the same risk?
Apparently not. The source contrasts exposure after age 30, which seems to have minimal carcinogenic effect on the breast, with exposure before 30, which substantially increases risk.
What kind of radiation are we talking about?
Examples given include things like multiple chest fluoroscopies back in the day, or high-dose radiation treatment for Hodgkin's disease if the chest was irradiated before age 30.
But not things like radioactive iodine for thyroid?
No, that's specifically mentioned as not associated with increased risk. But mediastinal radiation to the center of the chest for lymphoma in younger women is considered a powerful risk factor in the field.
That age distinction is really important. Okay, so summing up risk. Age, sex, hormones are the big three. Then family history, certain biopsy findings, early life radiation add to the picture. Let's dive into the genetics now, inherited susceptibility.
So the chapter starts by saying, yes, family history is a risk factor. Having a first-degree relative mother, sister with breast cancer increases your relative risk by about 30-50%.
That sounds like a lot for an individual.
It does, but the source immediately puts it in context. That family history only accounts for maybe 10-15% of all breast cancers.
Oh, okay, so most women diagnosed don't have that strong family link.
Exactly, which suggests that the risks seen in families could be due to maybe weaker genetic factors acting together, or shared environmental or lifestyle factors, or maybe genes we haven't even identified yet.
That's a crucial point. Family history matters, but it's not the whole story for most people. The chapter then makes that really important distinction again. Inherited versus acquired genetic changes.
Yes, and this is fundamental if you want to understand genetic testing. Inherited changes are germline, they're in every cell from birth. The source clarifies these are often called mutations, but technically they're SNPs, single nucleotide polymorphisms.
Right, SNPs, and there are different types.
Yep. Synonymous ones don't change anything functionally. Non-synonymous ones change an amino acid, which might matter, might not. And then the deleterious ones, these are the ones that mess up the gene's function or stop it working altogether, and that's what leads to higher susceptibility.
And then there are VUS variants of undetermined significance.
Exactly, where we just don't know yet what that specific SNP means clinically. Now, contrast all that with somatic changes.
The acquired ones.
Acquired within the cancer cells themselves during a person's life. These are what drive the cancer's bad behavior, the uncontrolled growth, the spreading.
So, germline SNPs create the susceptibility, the higher risk, while somatic changes actually fuel the fire of the cancer itself. The source also mentions normal genes act as suppressors.
Yeah, tumor suppressors. Their job is to fix somatic DNA damage or tell damaged cells to die off apoptosis. If you inherit a deleterious SNP in one of these tumor suppressor genes, its ability to do that job is impaired, hence higher cancer risk.
And the most well-known examples are BRCA1 and BRCA2.
Exactly. BRCA1 on chromosome 17, BRCA2 on chromosome 13. They're the best understood and most clinically significant inherited susceptibility genes.
What kind of risk do people carrying these mutations face?
It's significantly increased. The source quotes a lifetime risk of breast cancer between 60 and 80%.
60 to 80%.
Wow, and around a 33% lifetime chance of ovarian cancer as well.
That's incredibly high. Are these mutations linked to specific types of breast cancer?
Yes, and this is a really important connection for treatment. BRCA1 mutated cancers are almost always triple negative, meaning they lack ER, PGR, and HER2.
Okay. And BRCA2?
BRCA2 mutations are more often found in ER-positive breast cancers. Knowing this link is vital.
What about men carrying these mutations? You mentioned the 150.1 ratio earlier.
Men with deleterious SNPs, especially in BRCA2, do have an increased risk of breast cancer and also prostate cancer, but the source clarifies the absolute risk of breast cancer in men with a BRCA2 mutation is still much, much lower than it is for women carrying the same mutation.
So increased risk for men, but the scale is different. What's the overall prevalence of these BRCA mutations in the general population?
It's actually quite low. Less than 1% overall. And even among all patients diagnosed with breast cancer, it's less than 5%.
But it's higher in certain groups.
Significantly higher, yes. Around 2% in women of Ashkenazi or Eastern European descent. And importantly, about 20%, 1 in 5 women diagnosed with triple-negative breast cancer carry a deleterious germline BRCA1 SNP.
That's a key reason for testing in that group then.
Absolutely. The source also mentions other susceptibility genes beyond BRCA12, like P53 linked to Li-Fraumeni syndrome, PTEN, Cowden syndrome, PLB2. The list is growing.
So current genetic testing often looks at a panel of these genes.
Yes, that's common practice now, using panel assays that test maybe 30, 45 different germline genes at once from a blood sample.
But the source strongly advises against population-wide screening, testing everyone.
Right. And the reasoning is important. The rate of finding a truly harmful, deleterious SNP in the general population is just very low, less than 1%.
Okay.
Plus, you run into the problem of finding lots of VUS, those variants of undetermined significance, or finding changes in genes where the link to cancer isn't even proven yet. The source points out this can lead to a lot of confusion, anxiety, and potentially even inappropriate actions like preventative surgery based on uncertain results.
That makes a lot of sense. So who should be tested according to consensus guidelines?
The source lists several key groups. Anyone who has a family member already known to carry a deleterious SNP. Any patient diagnosed with triple-negative breast cancer patients diagnosed under age 40.
Okay.
Also, people with cancer in both breasts, either at the same time or one after the other. Anyone with a personal history of ovarian cancer, or a first-degree relative with breast or ovarian cancer.
What about men?
All men diagnosed with breast cancer should be tested. And some guidelines also include any breast cancer patient of Ashkenazi descent.
The source also flags a bit of controversy here, right? Some experts suggesting testing all breast cancer patients.
Yes, that recommendation is growing, and the driver is primarily treatment implications. We now have therapies, like PARP inhibitors, that are specifically effective against cancers with BRCA1 or BRCA2 mutations. So finding that mutation directly changes treatment options.
But it's still debated.
Still debated, according to this text, mainly due to the cost implications and the ongoing issue of managing VUS results.
Regardless of who gets tested, the source really hammers home the need for counseling.
Absolutely essential. Anyone found to carry an inherited deleterious SNP needs formal genetic testing and counseling. That involves a detailed discussion about their specific risks and what the options are for specialized screening or prevention strategies.
Okay, let's pivot to prevention then. Taking action against that risk.
The underlying idea is simple. Figure out someone's risk level so you can apply the right prevention or screening strategies efficiently. Now, the source notes that while lifestyle things like diet and exercise are great for general health, the evidence presented here doesn't prove they specifically decrease breast cancer risk.
Interesting. But avoiding combined HRT does help.
Yes, avoiding combined estrogen-progestin HRT definitely reduces that associated increased risk back down towards average levels.
Then there's the more drastic option, prophylactic surgery.
Bilateral prophylactic mastectomies. The source describes them as drastic, yes, but also highly effective. They can reduce the incidence and mortality from breast cancer by over 95%.
Over 95%. That sounds almost like a guarantee. But there's a caveat.
There is. The source points out that breast tissue isn't perfectly contained, so even after mastectomy, a tiny amount of normal tissue might remain, meaning there's still a very small residual risk of developing cancer in that area.
Who is this major surgery typically considered for?
Most often, it's for women with that very high inherited genetic risk, like BRCA carriers. That's where the evidence for reducing mortality is strongest.
And who should probably not go down this route?
Women with average risk or only mildly elevated risk. For example, someone who's had cancer in just one breast but doesn't have a strong genetic link. The source states survival isn't increased for them, and the procedure has significant downsides. Sexuality, cosmetic appearance, inability to breastfeed. It's just not considered appropriate for lower risk individuals.
Understood. What about chemoprevention, using medications?
Right. This involves using drugs to lower risk, primarily targeting that estrogen pathway. The main players are SERMs, selective estrogen receptor modulators.
Like tamoxifen?
Like tamoxifen, yes. And aromatase inhibitors, or AIs.
And you mentioned AIs have a specific restriction.
Yes, crucially, AIs should only be used in postmenopausal women. In premenopausal women whose ovaries are still working, AIs can actually cause a rebound effect and increase estrogen levels. Not what you want.
How effective are these chemoprevention drugs?
The source says they lower the risk of developing ER-positive breast cancer by about half. That's a pretty significant reduction for that specific subtype.
But only ER-positive?
Only ER-positive. They have no effect on preventing the more lethal ER-negative breast cancer.
There's one more prevention method mentioned, removing the ovaries.
Right, prophylactic oophorectomy, often including the fallopian tubes too, salpingo-oophorectomy. This is frequently done for women at high genetic risk, like BRCA carriers, mainly to slash the very high risk of ovarian cancer. But the source notes it also reduces breast cancer risk by cutting off the main estrogen source in premenopausal women.
So, several prevention options, from lifestyle adjustments to meds to major surgery, each targeted based on risk level and mainly impacting ER-positive disease or high-risk individuals. Now, how do we find cancer early? Screening and evaluation.
Screening mammography is really the cornerstone here. The source clearly states it leads to earlier diagnosis, which means you can start local and systemic therapies sooner.
Is there solid evidence it saves lives?
Yes. Randomized clinical trials have demonstrated that screening mammography cuts breast cancer mortality by about a fifth to a quarter, 20-25% in women aged 50 and older.
What about for younger women, say in their 40s?
The source says there's a similar relative reduction in mortality for the 40-50 age group. But because the baseline incidence of breast cancer is lower in younger women, the absolute benefit, the actual number of lives saved, is smaller compared to older women.
Makes sense. And screening also helps find cancers when they're more treatable with less invasive surgery.
Correct. More likely to find tumors at stages suitable for breast-conserving therapy. The source also mentions technology has improved a lot. Digital mammography, tomosynthesis, 3D mammograms, better views, better interpretation skills, all improving accuracy. For women at average risk, the text recommends screening only with mammography.
But you mentioned earlier there's some controversy around screening.
Yes, the chapter acknowledges the debate. While trials show that late mortality reduction, they haven't definitively proven a reduction in total mortality or a decrease in the incidence of advanced disease.
And the concern about overdiagnosis.
Exactly. Finding and treating cancers that are biologically insignificant, meaning they might never have caused harm if left alone. There's also the idea that because our treatments are so much better now, maybe the benefit of finding cancer super early via screening isn't as large as it used to be.
But real-world data tells a slightly different story.
It does. Epidemiologic studies from countries with widespread national screening programs actually show greater mortality reductions than the randomized trials did. It's a complex picture, valid points on both sides.
So what do the consensus guidelines generally recommend for frequency?
Most guidelines recommend annual screening for women aged 50 to 70. Many also recommend starting annually between 40 and 50. For women over 70, it becomes more of a personalized decision based on their overall health and life expectancy, involving discussion with their doctor.
The source does recommend MRI screening in specific high-risk situations, though.
Yes. MRI is recommended for women with particularly dense breast tissue, which can make mammograms harder to read. Also, if a woman's first cancer wasn't picked up by mammography, or if she presents with cancer detected in the axillary lymph nodes, but no mass is felt or seen on the mammogram.
And naturally, for those with high genetic risk.
Precisely. Women with known high-risk gene mutations like BRCA12 or related syndromes like Life-Romany or Cowden's. Also, importantly, women who had chest radiation therapy between the ages of 10 and 30.
Why MRI for these high-risk groups, given it tends to have more false positives than mammography?
The source explains that because the baseline risk in these women is so much higher, the positive predictive value of the MRI is also higher. So the chance that a suspicious finding on MRI is actually cancer is greater, making the lower specificity and risk of false positives a more acceptable trade-off compared to potentially missing an early cancer.
What about breast self-exams or clinical breast exams by a doctor? Are those still recommended for screening?
The source states that both have poor sensitivity and specificity for detecting early cancers. Regular breast self-examination is explicitly not recommended as a screening method based on the evidence presented.
That's a shift from older advice.
It is. However, the source does stress the importance of breast awareness. Women should be familiar with their own breasts and report any changes they notice promptly. A clinical breast exam by a healthcare provider remains an important part of a routine physical, especially if any suspicious findings are noted.
What about screening for men?
Not recommended for men at average risk. Breast cancer is rare in men and usually presents as a lump that's easily detected. But the source emphasizes any unilateral breast mass found in a man, especially over 40, should be taken very seriously and evaluated with a high index of suspicion, typically requiring a biopsy, just like in women.
Okay, so if a potential issue is found, either on screening or by exam, how is it evaluated? The chapter says diagnosis is almost always by biopsy.
That's right. Virtually all breast cancers are definitively diagnosed by taking a tissue sample, a biopsy of the abnormality.
And someone's personal risk factors don't negate the need for a workup if there's a suspicious finding.
Absolutely not. The source is very clear. Risk factors cannot be used to decide against a careful workup or biopsy if one is indicated by a finding. Any persistent breast abnormality needs referral to an experienced diagnostician to avoid delays in diagnosis.
For lumps that can be felt palpable masses, what features raise concern?
Things like firmness, irregular shape, if it feels stuck or tethered to the chest wall, or if there are skin changes like redness or that dimpled peau d'orange appearance. Features less likely to be cancer include painful masses or clearly cystic ones.
But there's a big caveat here.
A huge one. The source stresses that none of these features alone is highly predictive. You can't rely on them. And critically, if a woman has a persistent palpable lump, a negative mammogram does not rule out cancer. That lump still needs careful evaluation, potentially biopsy.
How does a menstrual cycle affect evaluation in premenopausal women?
If a finding is a bit ambiguous or not highly suspicious, the source suggests re-examining it in 2 to 4 weeks, ideally during the follicular phase of the cycle, days 5 to 7, when hormonal influence is lower. But any dominant mass in a postmenopausal woman or a dominant mass that persists through a menstrual cycle in a premenopausal woman needs prompt further evaluation and usually biopsy.
The source differentiates between diagnostic and screening mammograms in this evaluation phase.
Right. Diagnostic mammography is done after an abnormality is found, either by exam or on a screening mammogram. Screening is for asymptomatic women. If an abnormality pops up, diagnostic mammography is the next step for a closer look.
What kind of things look suspicious on a diagnostic mammogram?
Things like clusters of microcalcifications, especially if they're varied in shape or arranged linearly, densities or masses, particularly if they have spiculated or irregular borders, and any new or growing architectural distortion of the breast tissue. Ultrasound is often used alongside mammography here, especially to tell if a lesion is a simple cyst or solid, or to help guide a biopsy needle.
And follow-up depends on how suspicious it looks.
Exactly. If it's clearly benign on diagnostic workup and not palpable, routine follow-up is fine. If it's a non-palpable lesion with low suspicion, repeating the mammogram in 3 to 6 months might be reasonable. But again, if there is a palpable lump, even with a negative mammogram, that lump needs attention if it persists or grows biopsy is likely indicated.
What about the tricky situation of finding a breast mass during pregnancy or lactation?
It's unusual, about 1 in 3,000, 4,000 pregnancies, but it happens. Diagnosis is tough because the breasts are dense and changed by hormones, making exams difficult.
And the key takeaway from the source here.
You cannot just assume a dominant mass that appears during pregnancy or lactation is due to hormonal changes. It must be properly evaluated diagnostically. Stage for stage, the prognosis is similar to non-pregnant women of the same age, but sadly, diagnosis is often delayed in pregnancy, leading to more advanced stages, likely because the significance of the mass is underestimated or attributed to the pregnancy itself.
That potential for delay sounds like a real pitfall. Okay, we've covered finding and evaluating potential cancers. Let's move into what the pathologist sees the actual findings from biopsies.
Right. So when a biopsy is done for a suspicious finding, it turns out only about 1 in 5 to 1 in 10 is actually cancer. The rate varies.
So most biopsies are benign. What's the most common benign finding?
Fibrocystic changes are the most frequent things, like cysts, areas of increased cell growth called hyperplasia, and fibrous tissue.
Do any of these benign findings increase future cancer risk?
Some do. The source highlights that findings involving proliferation of the ductal or lobular cells, seen in about 30% of biopsies, do confer a higher risk. Even more significant is atypical hyperplasia.
Atypical hyperplasia. That sounds more concerning.
It is. It's found in a small fraction, maybe 3% of biopsies, but it carries about a 4-fold greater risk of developing invasive cancer later compared to women who haven't had a biopsy. And that risk is even higher if the woman also has a first-degree relative with breast cancer.
How is atypical hyperplasia managed then? Does it require aggressive treatment?
Management usually involves continued routine follow-up imaging. Importantly, the source states that chemoprevention using an anti-estrogen drug like a SERM or an AI should be considered for these women to reduce their future risk.
But not usually prophylactic mastectomy just for atypical hyperplasia.
No, the source says that's not normally indicated. For other benign findings without atypical features, there's little increased risk and routine follow-up is sufficient.
Okay, next up are the non-invasive breast neoplasms, often called in situ carcinoma, stage 0.
Right. Thinking back to that progression model, these are cancers where the malignant cells are still confined within the original duct or lobule. They haven't broken through the basement membrane to invade surrounding tissue. We're finding more of these now because of increased mammography screening.
There are two main types, DCIS and LCIS, and the source says managing both can be controversial.
Yes, ductal carcinoma in situ, DCIS, and lobular carcinoma in situ, LCIS, or sometimes called lobular neoplasia in situ, LNIS. Let's start with DCIS.
Okay.
This is where malignant epithelial cells are multiplying within the ducts. Pathologically, it can sometimes be hard to distinguish from atypical hyperplasia.
It's often described as premalignant. How likely is it to become invasive if left untreated?
The source estimates that at least a third, maybe more, of untreated DCIS lesions will progress to invasive cancer within about 5 years.
A third is significant, but that means maybe 2/3 won't. At least not quickly. Is that the overtreatment concern?
Exactly. Many lower-grade DCIS lesions might never progress or progress very slowly. The problem is, as the source states, we don't currently have reliable ways to tell the progressors from the non-progressors.
So what are the treatment options? Mastectomy.
Mastectomy is an option and is nearly 100% effective for preventing cancer in that breast. It's essentially prophylactic for the treated breast. But the source notes it's often not actually required for adequate treatment of DCIS.
What about breast-conserving therapy? Lumpectomy.
Yes, that's the main alternative. Surgery to remove the area of DCIS, lumpectomy or wide excision, usually followed by radiation therapy. The nearly 100% 10-year survival rates with this approach suggest it's generally a very effective strategy.
Is radiation always needed after lumpectomy for DCIS?
Generally, yes. A key randomized trial showed that adding radiation after wide excision significantly reduced the chances of the DCIS, or invasive cancer, coming back in that breast compared to excision alone.
What about adding endocrine therapy like tamoxifen or an AI?
Adding endocrine therapy does further improve local control, reducing recurrence risk even more when added to surgery and radiation. However, one large trial comparing tamoxifen to anastrozole, an AI in DCIS, did not show that the AI improved distant disease-free or overall survival compared to tamoxifen. The source also mentions certain features that suggest a higher risk of local recurrence after lumpectomy, even with radiation. Things like very extensive DCIS, being diagnosed under age 40, or aggressive-looking cells, poor-grade necrosis, comedo subtype, HER2 overexpression. These might lead to recommending mastectomy instead.
What about those newer gene expression tests for DCIS?
Yes, the source mentions multifactorial gene expression assays that have been shown to predict the risk of recurrence after lumpectomy without radiation. However, it's still not entirely clear if a low risk score on these tests is definitively enough to safely skip radiation. It becomes a discussion about risk tolerance versus the side effects of radiation.
And the lymph nodes. Do they need to be checked in DCIS?
For small, localized DCIS, usually not. Axillary node evaluation is generally unnecessary. However, the source suggests considering sentinel lymph node SLN biopsy for cases of widespread, larger, or higher grade DCIS, or if the initial core biopsies showed possible microinvasion.
Why check the nodes in those specific DCIS cases?
Because there's a higher chance that when the final surgery, lumpectomy or mastectomy is done, some unexpected invasive cancer might be found. If that happens, you would have needed the SLN biopsy anyway. Doing it up front avoids a potential second surgery just for the nodes.
So DCIS management involves balancing risk, often with lumpectomy plus radiation, maybe endocrine therapy, and sometimes SLN biopsy.
Yeah.
Now what about the other type, LCIS, LNIS?
Lobular carcinoma in situ is different. Here, the malignant cells are inside the lobules. Unlike DCIS, LCIS usually doesn't form lumps or show up as suspicious findings on mammograms. It's typically found incidentally when a biopsy is done for some other reason.
Is LCIS usually localized?
No, quite the opposite. The source states LCIS is often spread throughout the breast tissue, and very frequently it's bilateral, found in both breasts.
Does having LCIS directly increase mortality risk?
No, the source clarifies that an LCIS diagnosis itself doesn't directly increase the risk of dying from breast cancer. However, it acts as a significant marker, substantially increasing the risk of developing an invasive cancer later on.
How big is that future risk?
If a woman with LCIS doesn't have prophylactic bilateral mastectomies, she faces about a 1% risk per year of developing invasive cancer in either breast. This risk persists for at least 15-20 years, probably lifelong.
So LCIS is also considered pre-malignant, perhaps even more commonly so than DCIS. But the risk manifests differently as a risk factor for future invasive cancer rather than direct progression.
Exactly. And given its often diffuse and bilateral nature and generally lower risk of immediate progression compared to high-grade DCIS, aggressive local treatment like bilateral mastectomy seems less reasonable as a default unless there are other very high-risk factors.
So what is the usual management approach for LCIS?
Often it's less aggressive. Options include careful observation with annual mammograms, plus considering chemoprevention with a SERM or an AI for postmenopausal women for 5 years. After the chemoprevention course, continued surveillance with annual mammograms and semi-annual physical exams is recommended.
Bilateral prophylactic mastectomy is still an option, though.
It is an alternative, but the source makes a point of saying that this major surgery has not been shown to prolong overall survival any more effectively than the less aggressive approach of observation and chemoprevention. And of course, it comes with significant cosmetic and emotional consequences.
Okay, so LCIS is typically managed more conservatively, reflecting its nature as more of a risk marker. Now, finally, the invasive breast cancers.
Right. These are the ones that have broken out of the ducts or lobules and invaded the surrounding breast tissue. This gives them the potential to metastasize, spread to other parts of the body, and cause morbidity and mortality.
What are the most common types?
About 85% are invasive ductal carcinoma originating from the ducts. Around 10% are invasive lobular carcinoma or mixed ductalobular. And the remaining 5% or so are various special types.
Special types like?
Mucinous or colloid carcinoma, tubular carcinoma, medullary carcinoma, papillary carcinoma.
Do these special types generally have a better prognosis?
The source indicates they tend to have a more favorable prognosis compared to the standard ductal or lobular types, although that's not a universal rule for every single case or type.
All right, so we've got the pathology down, benign, in situ, invasive. How do we stage invasive cancer once it's diagnosed?
Well, traditionally, staging was heavily based on the T&M system. T for tumor size, N for regional lymph node involvement, and M for distant metastases.
But modern staging is more complex.
It is, yes. It now incorporates not just the anatomy, but also the tumor grade and those critical biological markers, ER status, HER2 status. It makes the staging system more complicated, but also much better at predicting prognosis and guiding treatment. Staging can be clinical, done before treatment, or pathological, based on what's found after surgery.
So it's really moved beyond just how big it is and where it's spread anatomically.
Absolutely. The source emphasizes that specific biological factors like grade, ER, and HER2 are often more critical now than just the anatomical stage alone for understanding prognosis and predicting treatment response.
When someone is diagnosed with invasive breast cancer, do they always need scans to look for distant metastases?
Not necessarily. The source provides specific guidance. Imaging for distant spread, like CT scans, bone scans, is generally not needed for patients who have no signs or symptoms suggesting metastasis and have a relatively smaller tumor, T3 or less, and fewer than 4 involved axillary lymph nodes.
Why skip the scans in that group?
Because the likelihood of finding actual distant metastases in that specific lower risk group is quite low. The risk of getting false positive results from the scans leading to more tests, anxiety, cost likely outweighs the small chance of finding true metastatic disease in asymptomatic patients with limited primary disease.
What about detecting microscopic disease like micrometastases in bone marrow or circulating tumor cells in the blood?
The source notes that finding these is associated with a worse prognosis. However, it also states that we haven't yet figured out how to best integrate these findings into routine care. So currently, testing for these is not recommended for making treatment decisions in early-stage disease.
Okay, so staging is sophisticated, combining anatomy and biology, But routine scans for spread are reserved for higher risk situations. Let's move into treating early-stage breast cancer.
Right. For patients whose cancer hasn't obviously spread distantly, the main goal is cure, or at least substantial prolongation of survival. Treatment generally breaks down into two parts: primary or local therapy and systemic therapy.
Primary therapy being surgery and radiation targeting the breast and nodes.
Exactly. Aimed at getting rid of the cancer locally, minimizing the chance of it coming back there, while trying to maintain quality of life and cosmetic outcome.
And systemic therapy targets potential microscopic spread.
Precisely. It's usually given after the primary local therapy. That's why it's often called adjuvant therapy. It aims to kill off any micrometastases that might have already escaped the breast but are too small to detect. This includes things like chemotherapy, endocrine therapy, and anti-HER2 therapy.
How are the decisions made about which adjuvant therapies to use or whether to use them at all?
It's guided by a combination of prognostic factors predicting the risk of recurrence and predictive factors predicting response to specific treatments. Plus, of course, the patient's overall health and preferences play a big role.
Let's nail down that distinction again. Prognostic versus predictive factors. It seems crucial.
It really is. Prognostic factors tell you the inherent risk of the cancer coming back if you did nothing after local treatment. They help decide if systemic therapy is needed. Predictive factors tell you if a specific type of systemic therapy is likely to work against that particular cancer. They help decide which therapy to choose.
So what are the most important prognostic factors mentioned?
Anatomical features remain very important. Obvious signs of locally advanced disease on exam, T4 features like skin involvement, chest wall fixation, mean a poorer prognosis. If those aren't present, then the two most important factors are the tumor size, T, and whether cancer has spread to the regional lymph nodes, N. The source includes a table 79-2, that clearly shows how survival rates drop as T and N stage increase. Beyond anatomy, the biological features are also key prognostically. Histologic grade, how abnormal the cells look under the microscope, matters. Grade 3, poorly differentiated, has a higher recurrence risk than grade 1, well differentiated. And as we've discussed, ER, PGR, and HER2 status are profoundly prognostic because they define those intrinsic subtypes.
Right, the intrinsic subtypes, luminal A, luminal B, HER2 amplified, basal triple negative, each having a different natural history and prognosis.
Exactly. Luminal A, high ER, low proliferation, generally has the best outlook. Luminal B, also ER+, but often lower ER, higher proliferation, has a worse prognosis than A. HER2 amplified used to have a poor prognosis, but targeted therapies have dramatically improved that. And basal, or triple negative, lacking all three receptors, tends to be aggressive, high-grade, with a generally poorer prognosis, though some subtypes respond well to specific chemotherapies.
The chapter then discusses using multi-parameter gene expression assays to refine prognosis even further.
Yes, this is a major advance, especially helpful for making decisions about chemotherapy in women with node-negative, ER-positive, HER2-negative cancer, that specific group.
What do these tests like Oncotype DX actually measure?
They look at the activity levels of a panel of genes within the tumor tissue genes related to proliferation, estrogen signaling, HER2, invasion, etc. Based on this pattern of gene expression, they calculate a recurrence score or risk category.
And how does that score help decide about chemotherapy?
For that specific group, node-negative, ER plus A, HER2-negative, who will receive endocrine therapy anyway, the score refines their individual risk. Patients with a low recurrence score, often corresponding to luminal A type, have such a good prognosis that the added benefit of chemotherapy is minimal, and they can safely skip it, avoiding the toxicity. The source notes this often applies to intermediate scores too. Patients with high recurrence scores, more like luminal B, have a higher risk, and for them, the benefits of adding chemotherapy clearly outweigh the risks.
So these tests primarily help identify who doesn't need chemo, rather than definitively proving who does among the higher risk patients.
That's a good way to put it. They are excellent tools for de-escalating therapy in patients with biologically favorable tumors, based on a more precise prognosis than just anatomy alone. The source mentions the 21-gene Oncotype DX has the most data supporting its use for guiding these decisions. It also cautions to only order one such test per patient because they don't always agree.
Are these gene assays useful for patients with more advanced stages, like positive nodes?
The source says their role in higher anatomical stages, like T3, T4, or multiple positive nodes, is still being investigated. Less clear benefit there currently.
What about simpler markers of growth rate, like Ki-67 staining? Is that used routinely?
The source notes that Ki-67, a marker of cell proliferation, does correlate with early relapse. However, its practical use is problematic because results can vary significantly between labs, and there's no universal agreement on the cutoff points. So according to this text, Ki67 expression is not currently used in standard practice to make major treatment decisions outside specialized labs.
Okay, shifting to predictive factors, determining which therapy to use. What are the gold standards?
The most reliable and clinically validated predictive factors remain ER status, predicting benefit from endocrine therapy, and HER2 status, predicting benefit from anti-HER2 therapies. The source stresses these must be tested on all primary and metastatic biopsies.
How exactly does ER status predict endocrine therapy benefit?
Endocrine therapy is highly effective for ER-rich cancers, usually defined as 10% or more cell staining positive. It provides essentially no benefit for ER-negative cancers, 0-1% staining. For the gray area of 1-9% staining, the evidence is weaker. But given endocrine therapy's relatively low toxicity, it's often recommended, perhaps with a lower threshold to stop if side effects occur.
And HER2 status for anti-HER2 therapies like trastuzumab.
It's a classic predictive marker. Anti-HER2 therapy dramatically reduces recurrence and improves survival, but only in HER2 positive cancers. It has zero effect if the cancer is HER2 negative. Status is determined by IHC, protein level, or FAISH, gene amplification.
Can you recap the interpretation? IHC3+ is positive.
Right. IHC3+ is positive, IHC 0 or 1 plus is negative, IHC2+ is equivocal and needs reflex of FISH testing. For FISH, a ratio of HER2 gene copies to chromosome 17 signals of 2.0 or more means it's amplified, positive. If one test is clearly positive or negative, the other isn't usually needed.
Now, the big question, are there any reliable factors to predict whether chemotherapy will work for a specific patient or tumor type?
According to this source, the answer is largely no. There are currently no reliable predictive factors for benefit from chemotherapy in general, or for specific types of chemo.
Really? Despite knowing about luminal A, luminal B, triple negative?
Correct. While there are hypotheses, maybe chemo works better in ER-negative or HER2 positive cancers, maybe luminal B is more sensitive than luminal A. These are not established predictive markers used to make clinical decisions. The source explicitly warns against using intrinsic subtype tests to withhold chemotherapy from someone with a poor anatomical prognosis based on a perceived prediction of resistance.
And attempts to find markers for specific chemo drugs like anthracyclines or taxanes haven't panned out either.
Largely unsuccessful. However, the source does note a couple of exceptions emerging. Platinum chemotherapies, cisplatin, carboplatin, seem to have higher activity in triple-negative cancers and maybe HER2 positive ones. And PRP inhibitors are clearly more active in tumors with faulty DNA repair, specifically those with BRCA mutations. These are steps towards predicting chemo response based on biology, but not a universal solution yet.
Okay, let's break down the specifics of adjuvant systemic therapies, starting with endocrine therapy. Who gets it?
Nearly all patients with ER-positive breast cancer should be offered it. It's never used for ER-negative cancers. The mainstays are SERMs like tamoxifen or strategies to achieve estrogen ablation, removal, or suppression.
How effective is tamoxifen?
Very effective. It prevents new cancers, reduces local recurrence in DCIS and invasive, and cuts the risk of distant recurrence and death in invasive cancer by about 40% over 10 years. It works in both pre- and postmenopausal women, maybe slightly less effective in the very young.
What are the main side effects of tamoxifen?
They stem from its mixed actions. Anti-estrogen effects cause things like hot flashes, vaginal dryness, joint pain. Estrogen-like effects can reduce osteoporosis risk in postmenopausal women, but also increase the risk of blood clots and, rarely, endometrial cancer.
And estrogen ablation strategies. They differ by menopausal status.
Yes. For premenopausal women, it means either surgically removing the ovaries, oophorectomy, or chemically shutting them down with drugs called GnRH agonists or antagonists. For postmenopausal women whose ovaries aren't working much anyway, estrogen is still made elsewhere, mainly by an enzyme called aromatase in fat cells and the tumor itself.
So you target aromatase in postmenopausal women.
Exactly. Using aromatase inhibitors AIs like anastrozole, letrozole, or exemestane. They block that enzyme, dropping estrogen levels extremely low.
Are AIs generally better than tamoxifen?
In postmenopausal women, yes, the source states AIs are slightly more effective than tamoxifen. The 3 available AIs seem to have similar effectiveness and side effect profiles.
And AI side effects are mostly due to that very low estrogen.
Correct. More intense hot flashes, musculoskeletal aches and pains, vaginal dryness, sexual dysfunction. A key issue is they induce or worsen osteoporosis and increase fracture risk. This needs monitoring and can be managed with bone-strengthening drugs.
How are AI side effects managed if they become problematic?
Things like physical therapy, NSAIDs for joint pain. Sometimes switching to a different AI helps, maybe a third of the time. Non-hormonal options like acupuncture or the antidepressant duloxetine can help some symptoms. If AIs are truly intolerable, switching back to tamoxifen is an option, if no contraindications like clot history. Antidepressants are also commonly used for hot flashes from either drug class.
What's the best endocrine approach for premenopausal women?
It depends on their prognosis and preferences. Achieving complete estrogen depletion using ovarian suppression plus an AI is slightly more effective than tamoxifen alone, but often comes with more severe menopause-like side effects.
So higher-risk premenopausal women might get the ovarian suppression plus AI.
Generally, yes. For worse prognosis, like positive nodes, that combination is often recommended. For more favorable prognosis, tamoxifen alone, or perhaps tamoxifen plus ovarian suppression, might be considered adequate and potentially offer better quality of life. And again, the source stresses. Never give an AI alone to a premenopausal woman with working ovaries due to that rebound risk.
How long does adjuvant endocrine therapy typically last? The standard used to be 5 years.
It used to be 5 years, yes. And 5 years provides significant benefit during treatment and for a few years after. However, a critical point the source highlights is the risk of late recurrence.
Late recurrence.
Yes, especially for ER-positive disease. The risk doesn't just disappear after 5 years. There's a small but persistent annual risk, maybe 0.5% to 3% per year, depending on the initial stage that continues for 15, 20 years, potentially lifelong. Because of this, extended endocrine therapy continuing for another 5 or even more years beyond the initial 5 is often considered. It does continue to reduce that late recurrence risk.
How is the decision made whether to extend therapy?
It's complex. It involves weighing the patient's initial risk, tumor size, node status, how well they're tolerating the current therapy, potential cumulative toxicities, and importantly, the patient's own perception of the benefits versus the risks and burdens of continuing treatment.
Okay, let's switch to adjuvant chemotherapy regimens.
Yeah.
Is combination chemo always necessary?
Using multiple chemo drugs, either together, combination, or one after another, sequential, is more effective than just using a single drug. Combinations are common, but sequential single agents can be just as effective, maybe slightly less toxic overall, but take longer to administer.
What's the optimal duration?
Usually 4 to 6 cycles, which might translate to 3 to 6 months depending on the schedule. Fewer cycles are less effective. More than 6 generally just increases toxicity without adding benefit.
Can chemo be given at the same time as endocrine therapy?
No. The source says concurrent endocrine therapy is not useful. Endocrine therapy typically starts after chemotherapy is finished. The exception is HER2 positive disease, where anti-HR therapy is given concurrently with chemo.
What are the workhorse chemo drugs mentioned?
The key players include alkylating agents like cyclophosphamide, anthracyclines like doxorubicin and epirubicin, antimetabolites like 5-FU, capecitabine, methotrexate, taxanes like paclitaxel and docetaxel, and platinum salts like cisplatin and carboplatin. Within drug classes, trials haven't consistently shown one is superior to another, e.g. doxorubicin versus epirubicin. The source also mentions evidence supporting dose-dense scheduling, giving chemo more frequently, like every 2 weeks instead of every 3, with growth factor support. Meta-analyses suggest this is advantageous for many regimens.
What are some standard combination examples?
The older standard was CMF, cyclophosphamide, methotrexate, 5-FU. Adding an anthracycline, like AC, improved outcomes slightly, but added small risks of heart issues and secondary leukemia. Then, adding a taxane to an anthracycline regimen, like AC followed by T-paclitaxel, further modestly reduced recurrence and death. Adding an anthracycline to a taxane-cyclophosphamide combo, like TCH includes carboplatin, is also effective.
How is the specific chemo regimen chosen for an individual?
It has to be personalized. It depends on the patient's prognosis, how high is the risk, their other health issues, comorbidities, and their preferences regarding side effects versus potential benefit. For a high-risk patient, even a modest relative benefit from a tougher regimen like ACT might translate into a large absolute benefit justifying the toxicity. For a lower-risk patient, that same modest relative benefit might only yield a tiny absolute gain, making a less toxic regimen like TC preferable.
Let's touch on neoadjuvant chemotherapy, giving chemo before surgery.
Right. Neoadjuvant therapy means giving the systemic treatment, usually chemo, but sometimes endocrine therapy for ER-plus cases, before the definitive local treatment, surgery radiation. Neoadjuvant endocrine therapy is typically reserved for patients needing to delay surgery for some reason.
What's the main advantage of giving chemo first?
It can shrink the tumor significantly. Response rates vary widely, 10–75%, depending on the cancer subtype and chemo used. This downstaging can make tumors that were initially inoperable operable. It can also allow some women who weren't initially candidates for lumpectomy, breast conservation, due to tumor size to become eligible maybe around 15%.
Does giving chemo before surgery actually improve long-term survival compared to giving the same chemo after surgery?
That's a key point. The source explicitly states that overall survival is not improved by giving the chemo neoadjuvantly versus adjuvantly.
So if survival isn't better overall, why do it?
One major reason is it allows you to see in real time how well the cancer responds to that specific chemotherapy. And patients who have a pathologic complete response, or PCR, meaning no invasive cancer cells left in the breast or nodes at surgery, have a much better long-term prognosis.
What about patients who don't get a PCR? They still have residual cancer after neoadjuvant chemo.
That's a challenge. It's unclear if they simply had a worse prognosis to begin with, or if the chemo just wasn't very effective for them. Giving more chemo after surgery to these patients is appealing, but the remaining disease might be resistant. So often the focus shifts to non-chemo strategies if appropriate, like endocrine therapy if ER+, or different anti-AO2 therapy if HER2+. And the source highlights specific proven strategies for residual disease. For triple-negative patients with residual disease after certain chemo, adding adjuvant capecitabine improves outcomes. For HER2-positive patients with residual disease after neoadjuvant chemo plus trastuzumab, switching to the antibody-drug conjugate adutrastuzumab emtansine, TDM1 postoperatively, is superior to just continuing trastuzumab.
We should talk about the side effects of chemotherapy, the toxicities.
Absolutely. Common ones affecting almost everyone to some degree are nausea, vomiting, and hair loss, alopecia. Nausea, vomiting are usually managed well now with anti-sickness drugs. Scalp cooling can help some people reduce hair loss.
What about the more serious or potentially long-lasting toxicities?
These affect a smaller percentage, maybe 2–3% overall. There's the risk of low white blood cell counts, neutropenia, leading to fever and infection, usually managed with growth factor injections. A very rare risk, 0.5 to 1%, is developing secondary leukemia or myelodysplasia years later, linked mainly to anthracyclines and high-dose cyclophosphamide. Congestive heart failure is a rare risk with anthracyclines related to the total dose received. Peripheral neuropathy, numbness, tingling, pain in hands and feet is a major issue with taxanes, affecting 15–20% during treatment and potentially becoming chronic or permanent in 3–5%. And then there's chemo-brain cognitive difficulties many patients report. While some might be direct drug effects, a lot could be related to the stress, anxiety, fatigue of diagnosis and treatment. It usually improves over time after chemo stops.
Okay, now adjuvant anti-HER2 therapy. The main drug is trastuzumab.
Yes, trastuzumab, Herceptin, is the cornerstone. It's a monoclonal antibody targeting HER2. Adding it to chemotherapy for early-stage HER2-positive cancer significantly cuts recurrence and mortality risk.
How is it usually given?
Ideally, concurrently with chemotherapy, especially with taxanes. It's generally not given at the same time as anthracyclines because both can affect the heart, increasing the risk of cardiac dysfunction.
Is using more than one anti-HER2 drug better? Dual blockade?
Yes. Adding a second anti-HER2 antibody, pertuzumab, to trastuzumab and chemotherapy provides a modest additional benefit over trastuzumab alone. It leads to higher PCR rates in the neoadjuvant setting and reduces distant recurrences, maybe improving survival, especially in higher-risk node-positive patients.
And we already mentioned TDM1 for residual disease after neoadjuvant therapy. How long is adjuvant trastuzumab typically given?
1 year, 12 months is the standard optimal duration. 6 months is better than nothing, but clearly inferior to 12 months based on trial data.
Are the oral anti-HER2 drugs, the TKIs, used in the adjuvant setting?
Their role is limited there. While drugs like lapatinib, neratinib, and tucatinib work in metastatic disease, trials in the adjuvant setting haven't shown significant benefit. Lapatin didn't add anything to trastuzumab, and alone was worse than trastuzumab.
What are the main toxicities of these anti-HER2 therapies?
Generally, they're well tolerated. Trastuzumab can cause infusion reactions, usually mild. The main concern is potential cardiac muscle dysfunction, though symptomatic heart failure is rare in the adjuvant setting. Regular heart monitoring, echocardiograms, is necessary during treatment. Pertuzumab often causes diarrhea, usually manageable. TDM1, being an antibody-drug conjugate, carries chemo-like side effects like low platelets and neuropathy.
The source also discusses using skeletal strengthening agents, like bisphosphonates, in the adjuvant setting. not just for bone health.
Right. There's evidence, particularly in postmenopausal women, that adding adjuvant bisphosphonates like zoledronic acid or potentially clodronate might offer a small benefit in reducing breast cancer recurrence, especially bone recurrence, and potentially improving breast cancer mortality.
Interesting. So not just preventing osteoporosis from AIs, but maybe an anti-cancer effect too.
It seems so, specifically in the postmenopausal setting. The benefit wasn't clearly tied to one specific drug or tumor type in the meta-analyses. They also clearly reduced bone fractures.
So guidelines suggest considering them.
Yes. As COCO guidelines say, zoledronic acid or clodronate should be considered as adjuvant therapy for postmenopausal patients eligible for systemic therapy. Importantly, the source notes that denosumab, Prolia, while effective for osteoporosis, did not show the same benefit in preventing relapse or reducing mortality in the adjuvant breast cancer setting.
Lastly, for adjuvant, the source mentions novel agents being tested.
Yes, highlighting the ongoing research. Things like PRP inhibitors for BRCA-mutated or similar cancers, mTOR inhibitors, and CDK46 inhibitors being tested alongside endocrine therapy. And of course, immune checkpoint inhibitors are being actively studied, showing promise, especially in triple-negative disease.
So the adjuvant landscape is complex, personalized, and evolving. Let's briefly touch on stage 3 breast cancer locally advanced disease.
This accounts for maybe 10-25% of diagnoses. It means larger tumors, T3, T4, or significant lymph node involvement, N2-3. Some might be technically operable up front, but many, especially those with inflammatory features or matted nodes, require treatment first.
What's a standard approach?
Almost always starts with neoadjuvant systemic therapy, usually chemo, to shrink the tumor and make effective local treatment possible. After surgery, mastectomy or sometimes lumpectomy, radiation is nearly always recommended, covering the chest wall or breast plus the regional lymph nodes. Adjuvant endocrine or anti-HI2 therapy is used as appropriate based on the tumor biology.
And these complex cases need a team approach.
Absolutely. Multimodality clinics are essential to coordinate the sequence of systemic therapy, surgery, and radiation. Even with aggressive treatment, the long-term disease-free survival is around 30-50% for stage 3.
What about the rare situation where someone presents with a new breast cancer and detectable distant metastases right at diagnosis, stage 4 at presentation?
This is uncommon now with screening, maybe 5% of cases. It happens if someone presents with symptoms from the metastases or if staging scans for a locally advanced primary find distant spread.
Is there a role for treating the primary tumor in the breast, surgery radiation, in this setting? Does it improve survival?
That's been studied. Retrospective data suggested a benefit, but prospective randomized trials have failed to show any overall survival benefit from aggressive local treatment of the primary tumor when distant metastases are already present.
So local treatment isn't standard for survival benefit in stage 5?
Correct. The current thinking, per the source, is that local therapy is considered case by case, mainly for symptom control, palliation, if the breast tumor is causing problems, or maybe after a good response to systemic therapy, depending on the patient's situation and wishes. It's not a routine part of the survival prolonging strategy.
Okay, let's shift now to a really important topic. Breast cancer survivorship. Millions of survivors out there now.
Yes. Huge progress means many more people are living long lives after diagnosis. And the source emphasizes that all clinicians, not just ontologists, need to understand survivorship issues.
What about long-term follow-up for survivors who are feeling well, asymptomatic? Should they be getting routine scans or blood tests to look for recurrence?
The current recommendation, based on strong evidence, is no. For an asymptomatic survivor with no concerning physical findings, special procedures like serial tumor marker blood tests or routine body scans, CT, PT bone scans, are not indicated.
Why not? If recurrence is a risk.
Because randomized trials have shown that while intensive surveillance might pick up a recurrence a few months earlier, this earlier detection does not translate into improved overall survival.
Really? Finding it earlier doesn't help live longer?
Apparently not, based on the completed trials. And the source points out the downsides of intensive surveillance, potential anxiety, false positives leading to more tests, and maybe getting toxic treatment sooner for a recurrence that wouldn't have caused symptoms for a while anyway, potentially worsening quality of life.
But the source does acknowledge that risk of late recurrence, especially for ER-positive disease, is real and persistent.
Yes, absolutely. It's a small annual risk, but it continues for many years, possibly lifelong, 0.5% to 3% per year, depending on initial risk. It doesn't just go away.
So how should doctors approach new symptoms in a survivor, given that background risk?
With careful assessment. Any new symptom needs to be evaluated thoughtfully, considering recurrence, a side effect of past treatment, or a totally unrelated issue. Judgment is needed to use tests appropriately, avoiding missing something treatable, but also avoiding the harms of overtesting. Serial echocardiograms are needed while on trastuzumab, but not after it's finished.
The source does float some ideas that might challenge the current surveillance approach in the future, though.
It does. It points to that unrelenting late recurrence risk, especially ER plus STO. It mentions the development of much more sensitive diagnostic tools, things like liquid biopsies looking for circulating tumor DNA, and more advanced imaging. And it notes we have increasingly effective targeted therapies.
So if we can find microscopic recurrence earlier and have better, less toxic drugs, maybe the equation changes.
That's the question. Could earlier intervention with these new tools and therapies actually improve survival, unlike the older surveillance studies? Ongoing trials are looking at exactly this. But the source is clear. As of now, there are no definitive answers to support changing standard practice away from symptom-based follow-up.
What about monitoring for those rare but serious late toxicities from chemo, like leukemia or heart failure?
Routine monitoring for those is not recommended. They're rare and best managed if and when they occur symptomatically.
What about managing the more common chronic side effects that impact quality of life for survivors?
This is critical. Hot flashes, sexual problems, joint pain, osteoporosis risk. These need active management. Estrogen therapy can help symptoms, but needs very careful consideration due to the potential impact on cancer recurrence risk, especially if ER plus lucibide. Local vaginal estrogen might be safer for local symptoms. Non-hormonal options are important too. Certain antidepressants for hot flashes pain, counseling, lubricants for sexual issues. Bone density needs closer monitoring, especially for women on AIs. All women need counseling on calcium, vitamin D, and bone-strengthening drugs should be used if osteoporosis develops or worsens.
So survivorship care is a long-term process, managing side effects, promoting wellness, and being vigilant for symptoms, but not necessarily doing routine intensive screening. Let's move to the final major section, metastatic disease.
Right. When the cancer has spread to distant sites, about 15-20% of patients treated for early-stage cancer eventually develop metastases, often years later, especially with ER plus disease. Common initial sites are soft tissues, bone, and visceral organs like lung and liver, roughly a third each. Most patients eventually get bone mets. Host factors like depression and obesity might influence recurrence rates too.
If a survivor develops symptoms suggesting metastasis, is biopsy always required?
Yes. The source strongly recommends biopsy to confirm metastasis, even with a known history. Benign things can mimic mets, do not assume.
And if metastasis is confirmed, should the tumor biology be rechecked? ER, HER2.
Absolutely critical. Retest ER and HER2 on the metastatic sample. They can change from the primary tumor in up to 15% of cases, and this directly impacts treatment options.
What about other testing on the metastasis? Mutation?
For ER plus mets, testing for PIK3CA mutations is mentioned to guide targeted therapy. For triple-negative mets, testing for PD-L1 expression helps predict response to immunotherapy. The source notes many experts now advocate broader genomic sequencing NGS on metastatic samples, though it's still considered somewhat controversial.
Once mets are confirmed, imaging is needed to see the extent of spread.
Yes. Whole body imaging is needed, bone scan plus CTs, or PT-CT. This maps out the disease, guides treatment, and helps decide if bone-modifying agents are needed.
Is routine brain scanning necessary?
Generally not without neurological symptoms. The exception noted is that some experts do recommend CNS imaging for HER2 positive patients even without symptoms, due to their higher risk of brain mets.
What are the goals when treating metastatic breast cancer? Is cure possible?
The source is blunt. Metastatic breast cancer is treatable, but rarely, if ever, cured with today's therapies. Median survival is under 3 years, but it varies hugely by subtype.
So if cure isn't realistic, what is the goal?
Primarily palliation, keeping the patient feeling as well as possible for as long as possible. A secondary goal is prolonging survival. And importantly, the source emphasizes these goals are best achieved not with more aggressive chemo, but by using selective, biologically targeted therapies based on ER and HER2 status.
How is response to treatment monitored?
Therapy usually continues until the cancer progresses or side effects become intolerable. Monitoring involves regular check-ins, physical exams, blood tests, liver function, blood counts, and often tracking tumor markers like CA15-3, CEA.
Is imaging needed frequently?
Only if the symptoms or blood markers suggest progression. If those are stable, routine imaging is unlikely to add much value per the source. If they suggest progression, then repeat the baseline whole-body imaging.
What about local treatment, surgery, or radiation in the metastatic setting?
They have a role, but mainly for palliation or preventing complications. Surgery might be needed for unstable bone lesions or maybe isolated brain mets. New back pain needs urgent MRI to rule out cord compression. Waiting is disastrous. Radiation is key for painful bone mets, brain mets, or problematic local recurrences. Sometimes systemic therapy is held during local radiation.
But aggressively removing isolated lung or liver mets doesn't improve survival.
Correct. The source states that approaches like surgical resection, RFA, cryotherapy for distant organ mets do not improve survival and come with risks and costs. They should be reserved for symptom palliation only.
What about treating a locoregional recurrence, chest wall, nodes, when someone also has distant mets? Is that treated differently?
Yes, that's presented as an exception. The goal there can be to render the patient disease-free locally with surgery and/or radiation, followed by systemic therapy appropriate for that recurrence, endocrine, chemo, anti-HER2. It's treated more aggressively than managing existing distant organ mets.
How is the systemic therapy chosen for metastatic disease?
Based on overall health, HER2 status, prior treatments, and clinical judgment. It's always balancing potential toxicity against expected benefit, remembering the palliative goal. ER-PGR positivity strongly favors endocrine therapy first, unless the disease is progressing extremely rapidly with organ compromise. Bone-dominant disease often runs a slower course. Managing symptoms and preventing fractures is key.
And all patients with bone mets need
concurrent bone-strengthening agents bisphosphonates, or denosumab. They are crucial for reducing skeletal complications like pain, fractures, and high calcium levels.
The source also emphasizes the importance of palliative care discussions.
Yes, noting that too often patients get toxic therapy late in the course of illness, recommends involving palliative care specialists, especially after 2 or more lines of therapy have failed for realistic goal setting.
Okay, let's quickly run through the specific systemic therapies for metastatic disease, starting with endocrine therapy for ER+.
Response rates are good, 30-70%. Options include SERMs, tamoxifen, AIs, and the SERD fulvestrant. Patients often respond sequentially to multiple lines of endocrine therapy. AIs are generally preferred first-line postmenopausally if not used recently. Fulvestrant often follows AIs. Combining different endocrine therapies doesn't seem to improve survival over sequential use. Combining endocrine therapy with chemo is not useful.
But combining endocrine therapy with targeted agents is a major advance.
Huge. Adding mTOR inhibitors, everolimus, improves progression-free survival, PFS. Even better, adding CDK46 inhibitors, palbociclib, ribociclib, imamaciclib, to AIs or fulvestrant substantially improves PFS and overall survival. This is now standard first-line therapy for most ER plus metastatic patients. Also, the PIK3CA inhibitor alpelisib helps if the tumor has that specific mutation. These targeted combos are used sequentially.
What about chemotherapy for metastatic disease?
Breast cancer responds to many agents, but combinations don't improve survival much over single agents used sequentially and are more toxic. So, single-agent chemo used sequentially is preferred unless disease is immediately life-threatening. There's no proven way to predict which single agent is best. Common choices include capecitabine, anthracyclines, taxanes, then others like gemcitabine, vinorelbine. Platinums are used more now, especially for triple-negative.
Anti-HER2 therapy for metastatic HER2 plus disease.
Trastuzumab plus azacitidine is foundational, improves survival significantly. Dual blockade with pertuzumab plus trastuzumab is even better first line. After progression, TDM1, adutrastuzumab emtansine, is effective. For further progression, fam-trastuzumab deruxtecan shows high activity. Oral TKIs, lapatinib, neratinib, tucatinib, also have roles, especially tucatinib, which showed benefit even in brain mets. Neratinib might also work for rare HER2 mutations without amplification.
PRP inhibitors for metastatic.
Olaparib and talazoparib are approved for patients with germline BRCA12 mutations. They work well, are often less toxic than chemo, but responses can be short-lived.
Sacituzumab govitecan.
An antibody-drug conjugate targeting TRP linked to chemo, SM38, shows good activity, especially in pre-treated triple-negative metastatic breast cancer.
And immune checkpoint inhibitors.
Mainly studied in triple-negative. Atezolizumab plus nab-paclitaxel improves PFSOS, but only if the tumor's immune cells express PD-L1. Side effects can be serious autoimmune reactions requiring careful management.
Lastly, bone-modifying agents in the metastatic setting.
Essential for all patients with bone mets. Bisphosphonates or denosumab. They significantly reduce skeletal events like pain and fractures. Osteonecrosis of the jaw is a rare risk, minimized by good dental care and less frequent dosing every 3 months versus monthly.
Okay, nearly there. 2 special cases, breast cancer and pregnancy.
Unusual, 1 in 4,000 pregnancies. Diagnosis often delayed. Workup is similar, but limit radiation exposure. Staging stands. Prognosis is stage for stage the same. Termination usually not needed. High-risk OB-oncology team is key.
Can chemo be given?
Yes, standard chemo, like AC, can be given safely after the first trimester. Taxanes, platinums maybe too. Avoid anti-HR2 therapies and endocrine therapy during pregnancy. Strategy is often neoadjuvant chemo after first trimester, deliver baby, then surgery radiation, followed by other needed adjuvant therapies. Discourage breastfeeding during after treatment.
And finally, male breast cancer.
Very rare, 1150th the rate of women. Risk factors include BRCA2 mutations, conditions causing high estrogen, like Klinefelter's, usually presents as a unilateral lump, often diagnosed late. Any unilateral male breast mass needs biopsy, especially over 40.
Biology and treatment.
About 90% are ER positive, behave like postmenopausal female ER plus cancer. Prognosis stage for stage is identical. Treatment is usually mastectomy plus node assessment, SLNB, or dissection. Radiation if indicated. Adjuvant therapy extrapolated from women tamoxifen is standard if ER plus AIs also work. Metastatic patterns and chemo response are similar to women.
Wow. We have covered an incredible amount of ground from Chapter 79, from the very basics of what breast cancer is, through risk, genetics, screening debates, the complexities of staging and treatment for all stages, survivorship, and these special populations. It's undeniably a complex and deeply nuanced field.
It really is, and mastering the details we've discussed, the subtypes, the prognostic versus predictive factors, the rationale behind sequencing therapies, understanding the evidence for screening or surveillance, that's what separates basic understanding from the kind of knowledge elite professionals need in this field.
And it's constantly changing, isn't it? All the mentions of ongoing trials, new targeted agents, evolving technologies.
Absolutely. That constant evolution is maybe the biggest takeaway. The knowledge is never static.
So, thinking about all that, especially the persistent long-term risk for ER-positive survivors, coupled with these emerging sensitive detection methods like liquid biopsies and the new targeted drugs, it really makes you think. Here's a final thought for you to ponder. If we get much better at finding microscopic recurrence really early, and we have more effective, maybe less toxic ways to treat it, what does cure even mean for breast cancer anymore? And how radically might our whole approach to long-term follow-up and intervention change in the coming years?
That's precisely the question driving a lot of current research. Can we leverage these advances to finally bend the curve on those late recurrences and truly improve long-term outcomes beyond today's standards? It's the critical question for the future.
It certainly leaves us with a lot to think about. Thank you for guiding us through this incredibly detailed source material. It's been a true deep dive.
My pleasure. It's powerful information when you put it all together.
We hope this exploration has given you, our listener, a much deeper, more structured understanding of the complex world of breast cancer, appreciating the science and the challenges involved. Keep exploring, keep asking questions.